It's a pleasure to be at least virtually together with you guys and give you a bit of an introduction in how machine learning, artificial intelligence, this is the broader term actually, can be used to potentially improve the clinical management of complex psychiatric disorders, but also improve the research into these conditions at the same time. I'm going to talk today more about what we say today, classical machine learning. This sounds like a very old thing, but it's actually not so old. We are talking about methods that have been at cutting edge 10 years ago. Nowadays, most of the people, when they hear the word AI, think about large language models, which is a different class of or family of methods. I'm not going to talk about LLMs today, but rather about, as I said, classical machine learning approaches, because for where we are in the field, I think they might be, although a bit less powerful, still quite useful. Let me move on with the slides. Yes, so this is the outline of the talk. I'm going to show you how AI can be used to understand heterogeneity in psychiatric disorders better, and particularly how that heterogeneity affects outcomes in randomized controlled trials, so RCTs. You know, this has been a very challenging field for drug development over the last decades, and with a lot of failures and a lot of millions of euros basically invested into negative trials, with compounds being discontinued in the development chain. And I think this is largely due to heterogeneity being unexplained. And we can use potentially AI to better understand that. I'm going to show you also how the AI can be used actually to improve treatment response, specifically in two different RCTs, one focusing on antipsychotic treatment in patients with first episode psychosis, and the other RCT basically examining response to repetitive transcranial magnetic stimulation in patients with chronic negative symptom schizophrenia. Then I'm going to focus on how the combination of different data modalities based on machine learning can help us to improve prediction and stratification of psychiatric illnesses, maybe even with the goal to bring this into clinical reality, clinical care, and how this can be basically aligned and mapped to the workflows that we usually follow as clinicians in clinical real world, where we do things sequentially. And then the final point will be, if we have enough time, to show you how to reduce heterogeneity via unsupervised machine learning, which is its own class of approaches. And at the very end, I'm going to discuss with you, hopefully, what possible pathways could be to make this work in clinical real world. Let me start with this aspect of heterogeneity in randomized clinical trials. As you most likely know from your own experience, but also from the literature, the heterogeneity of these disorders sits in two dimensions. One being the cross-sectional heterogeneity. Think about schizophrenia with the same patient, one or across different patients who have different phenotypes, which you would barely subsum under one condition, but this is what we currently do. If you think, for example, about depression, how many combinations of symptoms could lead to a person being diagnosed with major depressive disorder, this is just mind-boggling how many combinations that could basically give rise to that depression. But you have also heterogeneity from a longitudinal perspective, with some patients basically showing very good outcomes. For example, here patients with first episode psychosis as investigated in this quite old study from Gerd Huber. This is the guy on the left side. In the 70s and 80s of the last century, they followed them over 20 years, so 500 first episode patients, and then basically investigated their social recovery capacity, which is shown here on the right, and the course, the trajectory type that these patients had. And basically he and his workers found that everything is possible under the sky, I always say. So you have people who basically have one or two, a few episodes here, these green parts of the pie chart. Then you have people with an intermediate course, so 50% of the population, where you have monophasic courses with some residual symptoms. And then there is another quarter of the population, unfortunately. And this has not really changed so much, I would say, despite everything we do, all the treatments that we have. This quarter of the population has these kind of polyphasic courses with chronic poor outcomes, basically. And he said that at the baseline, it would be just impossible to predict with a certain level of certainty what the differentiation between malignant or benign processes would be. So that means it would be impossible. That was his view on the problem, to predict the outcomes of these individuals. Well, we doubted that this is really true, and we thought that there might be information, complex information hidden in clinical data available in RCTs, and we tested that in a large multi-site clinical trial, the UFES study, which was conducted across many different European countries. As you see here, it's also a relatively old study, more than 15 years old. And the study collected a lot of different information domains from these first episode patients with psychosis, about 500 patients. And the study tested 5 different standard antipsychotics against each other and measured realistic outcomes, so treatment adherence, remission, hospitalization, frequency, quality of life. And what is very important if you want to do machine learning, the study covered about 50 sites across Europe, which is crucial if you want to demonstrate generalizability of a prediction model, obviously. So what did we do? What did we try to predict? As Huber basically observed, we wanted to predict a functional outcome. Yeah? And here, this is the GAF distribution of this population. So the global assessment of functioning scale, going from 0 to 100. This measures basically functioning across a broad array of domains. And this is the baseline distribution. This is after 4 weeks, and this is after 52 weeks, so after 1 year. And you see that basically it's right shifting. Of course, people improve, yeah. Particularly first episode patients have luckily a tendency to improve, but this is the other side of the story, not all of them. As shown in the pie chart before, there is a group of individuals which poorly recovers, unfortunately. They have a GAF below 65 score points. So what we wanted to do is to test whether we can predict this dichotomous outcome. Yeah, 65, less equal 65, greater 65, with a broad set of variables which were analyzed by a classical machine algorithm. And here is the outcome of this analysis. What we measured was basically the performance, and I leave one side out setting. So we always took out one side, trained the algorithm on all other sides, and applied the algorithm to the never seen, held back side. And when you do that across all sides, you compute basically the performance of this algorithm, and the average performance was 74%. And here is the distribution of the decision scores. On the y-axis, you have the score generated by this support vector machine algorithm, and here just the number of individuals. So you see that there are, of course, misclassifications, but overall it doesn't perform that poorly. What is also very interesting is to open the box and to look inside the algorithm, what it practically has learned, what is predictive of a poor versus good GAF outcome after 4 weeks or after 52 weeks, which was here the time interval in this analysis. And we trained, and I have to say that we trained the algorithm in a way that it is as parsimonious as possible, because we had the clinical applicability in mind. We don't want to examine a patient for hours, right, until we can make an analysis. We want just to have the most important variables. And when you do this, we employed a wrapper algorithm to do this, which is kind of a Darwinistic approach to select the fittest sample of variables. And when you do that, you get something like this. So this is the relevance or the selection probability, if you want, of these algorithms. And here are the ones that were the fittest ones. Somebody who had an occupation at baseline had a much higher likelihood of developing a good outcome. Then you had a lot of items which measure basically the needs of the patient. The CA stands for the Camberwell Assessment of Needs Questionnaire. It's a long and complex questionnaire which basically asks the patient, but also the staff, about the needs of the individual. And you see that there are complex needs, a complex needs landscape that determines or that predicts outcome. There are also some other interesting variables. For example, the presence of recurrent major depressive disorder at baseline, which illustrates that it's the problem or the risk landscape is not limited just to schizophrenia, but entails also encompasses comorbidities, particularly across the affective spectrum. And this has been replicated or seen also in other problems, for example, in the transition to psychosis challenge. And so where we want to predict transition to psychosis, we see that patients who have an affective comorbidity tend to have higher transition rates. So this is something that we see across different stages of the disorder. It matters whether people have a pure psychosis. I don't know whether this even exists, but if they have affective comorbidity, this is basically a risk factor. And then you have, of course, previous diagnosis of schizophrenia. This is a predictive of poor outcome, and male sex was also predictive of poor outcome, as has been described in the literature. So when we do that, we can increase the prognostic certainty. So the baseline prevalence of poor outcome was 23% after 1 year, so it's a 52-week outcome. And good outcome was 77%. If you add this as a prognostic test to this baseline prevalence, you can increase the certainty to over 50%, and further also increase the certainty of the good outcome. And we call this the prognostic gain, the prognostic certainty that you gain through the application of the algorithm in this given population. And this is considerable. It's about 40% gain of prognostic certainty. So what do we actually predict when we build this model? And this, I think, is a crucial step if you want to develop such an algorithm. You want to see what it actually predicts. Does it predict just the label or more than that? And to test this, you need to basically take the labels, the predicted labels, not the observed ones, the predicted labels as a stratifier, and take this across two different variables. So for example, treatment discontinuation. You see basically that the people who had been predicted with a poor outcome by the algorithm were much more likely to drop out of the study. They had, of course, a lower functional level. This was the primary endpoint of the analysis, but they had also poorer quality of life, as shown here across the work, leisure, friendships, and health domains. They were much less likely to remit from the symptomatology, and they were much more likely to re-hospitalize during this 52-week interval. So the algorithm did not just learn to distinguish between GAF greater less 65% or 65 points, but it has learned a broader proxy of recovery capacity. This is basically what this analysis showed. What I think, however, from this study was the most important and interesting finding is shown here on this slide. So we looked now into the specifics of the antipsychotics given to different patient groups. And we investigated the error rate of the algorithm according to the medication given during this year. And we did this separately for the patients with a predicted good outcome versus the patients with a predicted poor outcome. Here you see the patients with a predicted recovery or a GAF greater 65. And these are the different, so this is the prediction error rate, the misclassification likelihood. If a patient was treated with haloperidol, olanzapine, quetiapine, amisulpride, or ciperazidone. And you see that there was not a lot of difference. There was no significant difference between these different groups. The story, however, changed completely when we looked at the patients with a predicted poor outcome. And what was striking actually is the following. Here you see that the algorithm was actually relatively good in predicting poor outcome in patients who received quetiapine, but it made a lot of mistakes when it tried to predict outcome in patients treated with amisulpride, which means that, and these two compounds obviously are very different. Amisulpride is actually an antipsychotic that I think has been developed, if I'm correct, in France, and is still quite popular in France, if I'm correct. It's also quite frequently prescribed in Germany, and we see that it has a lot of beneficial effects in terms of its antipsychotic potency. And that basically illustrates that if somebody received amisulpride, the prescription of amisulpride was beating the predictor's estimate. And this is something that, of course, shows the stratification power of the algorithm, which could be investigated in a future clinical trial, for example, where you would say a patient has to be seen by the algorithm. If the algorithm predicts a poor outcome, you would treat this person with amisulpride. And this would need to be obviously prospectively validated in a clinical study. That was the first little part of my talk. I would like now to go into prediction of treatment response in negative RCTs. There was a study conducted in Göttingen about 10 years ago, which tested the effect of repetitive transcranial magnetic stimulation applied to the DLPFC of patients with predominant negative schizophrenia. So we're talking now about not first episode anymore, obviously, but chronic schizophrenia patients with an illness duration of about 10 to 12 years. And this shows basically the study design. So there was a treatment period of 3 weeks of active versus sham RTMS and an extension phase of further 12 weeks. The trial was completely negative. So that was the kind of disillusioning outcome. So there was no difference at all. It was the most negative study I've ever seen actually in my life so far. And when Peter Falke and Alkamit Hassan, who were the PIs of the study, came to me, we basically discussed the findings, and I made the suggestion to try to still predict in this group who would benefit from the intervention. And we tested that with structural imaging data. So we had structural imaging data recorded at baseline, and then we ran a machine learning analysis using these data to predict response to the treatment after 3 weeks. And this is what came out of this analysis shown here. I'm going to guide you through this. So this is the pooled analysis. So there were 3 sites involved in this analysis, 3 different sites, not just Göttingen. There were 2 other sites. I think one was Düsseldorf, and the third one I can't remember. Sorry for that. But what you can see is there was a loss in performance when we moved from a pooled to a leave site out setting, which we had employed also in the UFAS study of about 13%, but still it was really, really okay in terms of performance. When we trained the same algorithm on the sham data, there was no predictability, which demonstrates that this was really the predictability was specific to the intervention applied in this population. And not only that, so here you see the baseline. This is the PANSS negative score, the primary endpoint score. These are the patients with predicted response, and these with predicted non-response. This was the primary endpoint after day 21. What you see is that actually the intervention was quite effective. but it was effective only in a subgroup of individuals. And it was so effective that it went on being effective after day 21. And this was obviously not the case for the sham-treated group. And there were brain regions associated or underpinning the prediction, and this is shown here. We found basically gray matter volume reductions and gray matter increases, but particularly gray matter volume reductions in the DMN, in the default mode network, and also the cerebellum, and also here in the temporal system, and the orbitofrontal cortex basically predicted non-response to treatment, which illustrates that actually structural brain changes drive the response capacity of the brain in this population in chronic schizophrenia. Okay, so that was the focus on how to use AI for resolving heterogeneity and improving, potentially in the future, patient selection for clinical trials. Yeah, so where we basically face a situation where we include a lot of individuals with heterogeneous outcomes, heterogeneous recovery capacity in one bucket, under one umbrella, and that might kill our basically efficacy signals in the RCTs. Now I would like to move on to look into the topic of predicting psychosis onset, as Marie-Odile said in the beginning, and leveraging different data sources to do that. As Marie-Odile said, we were fortunate to coordinate a large-scale EU study which focused on the topic of psychosis prediction using a multitude of different data. As a EU study, it was a multi-site project with different countries involved, different healthcare systems covered, as shown here. As you know, of course, the UK healthcare system is different from the one in Germany and from the one in Finland. This is crucially important to have this kind of coverage if you develop a machine learning algorithm, because you want it to be as generalizable as possible. You don't want to retrain it for each and every healthcare setting. We recruited 4 different groups, which are shown here, and obviously clinical high-risk individuals for psychosis, so meeting SIPS criteria for clinical high-risk states or cognitive basic symptoms criteria. I'm not going into details about that in this talk. And then we also had patients with recent onset depression, which were back then, and when we started conceptualizing the study, included as a clinical control group. And it turned out that it was a very wise decision to include these people in the study. We followed them over time, this is shown here, with a maximum of 36 months, and did a very comprehensive baseline examination and also a similarly comprehensive examination at 9 months. It should be similar to other early recognition studies, including the study that Marie-Odile coordinates in France, the psychiatry study, or the PsyScan study, which was on the filament wire. So we follow these individuals clinically every 3 months, and we stage them. So by reapplying the SIPS and by reapplying the schizophrenia pronus instruments for the assessment of cognitive basic symptoms. We applied this also to the recent onset depression. And this is where the first kind of surprise occurred. So of course, a lot of these patients with recent onset depression, they had the first depressive episode in their life, a lot of them remained asymptomatic with respect to the clinical high-risk criteria. And about 32% of clinical high-risk individuals became asymptomatic over the follow-up period. However, when you look at this here, you see already 18% approximately of these depressed patients developed a de novo clinical high-risk state during the study. And 55% of the CHR population remained symptomatic. So that also illustrates that the clinical high-risk state is not just a risk, it's not just a diathesis for the disease, but it's actually linked to a considerable impairment considerable burden of symptoms. So the people have the feeling of being observed, or they have bizarre thoughts, so they have not reached the threshold for a diagnosis, but still they are very burdensome. And this is my experience as a clinician also, when I see these patients, that they are really poor off. And some of them develop full-blown psychosis, about 14%, and a few depressed patients as well. So that can, in the end, we found out that about 1/5 of the depressed population developed some psychosis-related outcome, either CHR states or full-blown psychosis. And this illustrates that in that age window, we're talking about young people, so 23, 24 years of age. In that age window, these two conditions are relatively close to each other. With depression, as I said, depression worsening usually the course of these syndromes, or being like a broader risk, how to say that, level underlying the clinical high-risk state, from which further risk is recruited over time. So this is how I basically would see this. It's not just linked to the clinical high-risk states, risk for psychosis. It's a much broader risk architecture in the adolescence population and young adults than what we actually assume. And I think, therefore, it's important in studies, in these kind of early recognition studies, to open the window a bit more broadly and include patients with affective syndromes as well. Okay, so we interrogated our data with different machine learning algorithms, as I said. And this is now the result of it. So first of all, we applied a similar model as trained in UFAST, a similar strategy to the clinical data of our patients recorded at baseline. And we were able to predict their future transition to psychosis in a transdiagnostic sample of clinically high-risk people and patients with first episode depression or recent onset depression with an accuracy of 76% in a leave one side out cross-validation manner. And what was predictive was a set of course, that was not a big surprise, because there is literature on this already, that the prodromal symptoms themselves are predictive of outcome. Yeah, but there were some further interesting observations. So motor disturbances were predictive, which makes totally sense if you think about schizophrenia, and particularly developmental forms of the condition, which you can basically early on, you can observe neurological soft signs in these people. We had also grandiosity being predictive, and in facial emotion recognition abilities of these individuals, as well as, and this is a more environmental marker, the family situation, the family care situation of these individuals. So already at that level, you see kind of a multivariate landscape that is pointing towards transition or non-transition. Then we computed polygenic risk scores for schizophrenia for our individuals and trained our machine algorithm using those scores. And that model also performed significantly, but on lower levels. So it was 66% balanced accuracy, with the most lenient p-value threshold being the most predictive one, which means that polygenic risk for schizophrenia does not necessarily fully align with risk for transition into psychosis. It partly aligns, and if you make the threshold more lenient, you capture also the genetic architecture of transition risk, not just the genetic architecture of schizophrenia, which might be much more limited or confined. And then we also used structural imaging data, as in the previous study that I showed you, to predict transition. And we found that there is a pattern basically involving the cerebellum and the hippocampal system, but also the dorsal default mode network that was predictive of outcome. And that algorithm performed at a 71% balanced accuracy. However, if you want to bring this into clinical real world, you need to establish kind of a ground truth of performance. And we don't have any ground truth in psychiatry, obviously, because we don't have any objective biomarkers. but we can still compare the algorithms against the performance of our human pattern recognition abilities. And therefore, we ask our clinicians, after completing the baseline examination, to make a statement, to make a guess what they think would be the outcome of their patients after the baseline. This is, you have to take this with a grain of salt because this is not a real world setting. So this is a study. Patients were examined for a netto of 8 hours, and then clinicians or raters were asked to make a statement. And the outcome is shown here. So the performance is as good as the unimodal, the expert machine learning systems. So the performance is about 73% balance accuracy. Sensitivity is relatively low, 62%, while the specificity is quite good, 85%, which means that the clinicians are relatively good in ruling out future psychosis. If you take the combined machine learning algorithm that leverages all 3 data domains, clinical data, genetics, and imaging, this is obviously much better. It was about 83%, and significantly better than the clinicians alone. And we integrated all these information sources, including the clinicians, into what we call cybernetic prediction, into a cybernetic prediction approach. And we found basically that with this strategy, you can improve the performance further to about 86% with the clinicians and the genetics and the clinical neurocognitive data being the most important sources of prognostic information. Then another problem is that it's very expensive to do all these examinations in each and every individual. Yeah, doing an MRI scan, taking blood, doing genotyping. Of course, the cost of this have come down drastically, but still it's a significant deal of work and costs that would be associated with such an approach in clinical reality. So we were basically discussing in my team how to improve this and how to make it more feasible, more scalable to clinical real-world settings where we do things sequentially, right? So we see the patient for the first time, we take the history, we do a psychopathological exploration, and then we do potentially some blood testing and MRI scanning for exclusion diagnosis. And we devised an algorithm to basically find out the optimal sequence for us. Yeah. The optimal sequence of machine learning models to basically maximize prognostic precision. And the algorithm tested out different combinations, different uncertainty windows, when to send a patient from one examination to the next. And this is the winning sequence, which is basically exactly what we do in the clinic. So we acquire clinical data, we would analyze it with a machine learning algorithm, we would make our own statement on the patient, and then we would add biological examinations to refine the prediction. And this is basically what happens if you do that. First of all, the number of patients who need to travel all the way to the MRI scanner goes down drastically to about 40% of the population. What happens when patients travel to the scanner is that the false positive rate goes down. So that means not everyone, it's not random who needs an MRI scan. It's particularly those people who receive a prognosis of a disease transition initially. Those people, there are a lot of false positives in these initial predictions, and those people need to receive genetic testing and MRI scanning to basically rule out the false positives. This is not a unitary phenomenon limited to this specific task. It's something that we observe across different predictive challenges in psychiatry. And I want to briefly show you the results of the RCT where we basically predicted response to RTMS. And here you can see that the same principle holds but with a different order of examination. So we used back then in the previous slide just the structural imaging data, but we can use clinical data and polygenic risk score for schizophrenia as well, and combine those examinations. And when we do that, let the algorithm find the optimal combination. When we do that, the algorithm starts with a different sequence, starts with a different examination, structural MRI first, then clinical, then polygenic risk scores for schizophrenia. And here the blue line shows you the increase of balanced accuracy along the path. So reaching very high levels. Obviously, this is a small study. I don't expect this to be replicated easily, but it shows you the principle that the addition of complementary sources of information boosts prediction performance, also in this specific challenge. And also the case propagation likelihood goes down, as with the other example. Just looking at the time, there's a few minutes left. As the last part of the talk, I want to show you also the application of unsupervised machine learning methods to study heterogeneity. This is also a family of machine learning methods, which we use in our lab. And one of my former postdocs, now assistant professor in Melbourne, Dominic Wire, used this approach basically to decompose clinical heterogeneity of the combined pronia data set, including all these different phenotypes. And we basically threw this algorithm on a large set of variables and found that there are 4 subtypes or 4 dimensions, if you want, in this population, characterized by positive symptoms, negative symptoms, depression, and functioning. And the nice thing about this algorithm, which is a non-negative matrix factorization, this is the name of it, is that it basically also segments the population into subgroups. And you see here the positive subgroup, which contains primarily recent onset psychosis patients and CHR individuals, high positive symptoms, premorbid deficits, but a remitting course. They have the highest schizophrenia polygenic risk. Then you have negative symptoms, which was completely transdiagnostic, with incomplete remission, also high schizophrenia and high premorbid deficits. Then there was a depressive cluster, which was also quite transdiagnostic, but low polygenic risk for schizophrenia. Again, a remitting course, not so pronounced premorbid deficits, and a high functioning cluster where mostly healthy people were subsumed, but also some patients with the lowest premorbid deficit, stable course, and lowest polygenic risk for schizophrenia. He applied the same approach to the imaging data and found that there were basically 2 subtypes, one being a spared brain type and the other one an impaired brain type with gray matter volume and white matter volume reductions across the brain. I'm going to the next slide. And it was interesting to relate these 2 to each other. And he did that and found basically that the impaired brain type encompassed particularly the positive and negative symptom subtypes, whereas the spared or reference volume group included the depression group somehow, and particularly but however the high functioning group. When he combined that, he found that the multimodal cluster, there were 2 clusters, 2 multimodal clusters, brain and clinical data combined. They were quite associated with the trajectories of these individuals. So the impaired group had reduced premorbid adjustment across the lifespan up to the baseline. They had higher levels of negative symptoms, lower functioning, higher polygenic risk. So this basically shows you the variability that exists in this population and how this can be resolved with these algorithms. By the way, including or removing depression did not change anything, which further adds or corroborates what I said before, that depression and psychosis in that age window are closely related and potentially part of a larger continuum of disorders. And I would like to use this Matryoshka example to illustrate this phenomenon. You have at the brain level, you have 2 clusters. At the clinical level, you have 4. And these are kind of nested phenomena, where the brain, basically, the brain abnormalities, the brain subtypes constitute diathesis for developing or for developing into these clinical subtypes. This is how I like to think about it. Okay. Last few slides and then I'm done. What are possible ways forward for this kind of research? What are the challenges if you want to make a difference in clinical real world? First of all, I've shown you that to improve accuracy beyond clinical judgment, this is what we currently do, we need to integrate a lot of data across different measurements. This increases diagnostic burden, obviously. It increases costs for society. It increases potentially inequality between patients, as not everyone might have access to these examinations. And still, whatever you do, there are false positives and false negatives with which we might potentially need to live with. However, this needs to be weighted against, obviously, the huge costs of these disorders, and there is no means to decipher outcome heterogeneity at the moment into actionable prognostic or diagnostic estimates. There are risks, further risks that you need to be aware of this methodology becoming part of clinical routine. There are possible operator errors that can bias the prediction. There is potential reinforcement of structural bias, as I said, in society. There are still a lot of unknowns given the lack of sufficient external validation and calibration of models. So the whole field in itself of precision psychiatry is in its infancy, if we are honest with and frank, because there is a lack of external validity or unknown validity. There is a risk of black box predictions, by the way, particularly for large language models. And this can lead to very low acceptability. On the clinician side, if you're a clinician and you have to sell a predictive model to your patient, of course, it's much more difficult to do this for a black box approach, where you cannot look into the model, why it has produced a certain prediction for the given patient sitting in front. And if you are a patient, you of course want to know why you receive a certain prediction or a risk estimate. And you need to understand it first of all. And then you need to understand what drives that estimate to do something about it, to change course and to receive the right treatment that can modify that risk. There is a risk also, maybe as a last point, of a diffusion of responsibility away from clinicians towards AI systems. And this is potentially one of the biggest risks of this field. And it needs careful thought how this can be counteracted or prevented. How machines and clinicians can work effectively together. And what happens if there is disagreement? So that in the end, in the future world, not the clinicians, the onus is not on the clinician's side to justify their decisions against the super objective estimate of the machine. How can this be more specifically translated? So you remember the sequence that I showed you before. It could be scaled into clinical reality by increasing complexity according to pathways through the healthcare system, with primary care physicians basically having access to easy models, simple models that can be rapidly ran against their patients' data. And those initial first line models can basically create pathways for the patients through the healthcare system, where the healthcare resources are wrap around the patient and not the other way around as it is at the moment. So this is potentially the biggest benefit of this, that at the moment, the patients, this is what I see, young people, they basically run through the system, they run to clinicians, they are at the wrong place, receive diagnoses that are incorrect because people have not been trained to detect, for example, psychosis risk states, and a lot of time and money is wasted, which within this precision framework could be massively cut down. I think that such a system could generate data that can be used across different healthcare contexts, data that could be used to further improve those models over time, particularly with a focus on ethical AI. So to embed ethical approaches into the model building itself, and then run RCTs using these models and feed those models back into clinical real world using implementation science approaches, basically to close the loop. And with that, I think I'm done, and I'm happy to take your questions. Thank you so much for your attention.
I have one or two comments. I'm very interested by the fact that you use not only, you propose to use not only this algorithm to improve RCT, but also to understand why some of the RCTs are negative. And I think that I think that as NeuroPro, for example, studies were disappointing about the results. Probably this approach could be probably very informative about what kind of subtypes of patients could be more benefit to that. I don't know if you have a opportunity to realize that it's not always feasible, but
I absolutely agree with you. What we currently do is, let me be honest, it's a bit crazy. Yeah. So think about a neurological condition, for example, which in neurological patients, let's say with multiple sclerosis, in an era where MRI was not available in CT, and they would just be included into a clinical trial because of their symptoms. Nobody would do that. No. But this is what we have been doing for the last 50 years, basically. And it's no surprise that we don't have any improvement, any treatment innovation, because we are not including the patients based on their pathologies. This is potentially a means. It's not a silver bullet, no question about it, but it's certainly a means to define subtypes, dimensions of disease pathology that could be used to homogenize basically the populations that go into clinical trials. And because they are also able to expose disease pathology to treatment innovation. And I think this is where the biggest value is actually of this whole field. Of course, it's nice to have them in clinical real worlds, all these methods, but in the end, yeah, it's nice, but we cannot really go beyond what's available in terms of treatments.
Yeah. So, yeah, just one short question, and then for the floor, the audience to have the opportunity to ask other comments and other questions. You mentioned several times cerebellum as could be a part of the story. Unfortunately, in most of the studies right now, it's really not often, should I say, take into account, and we don't have the data. So all the algorithms we are constructing do not take into account cerebellum or maybe clinical manifestation of it. So what would be your best guess about what we should include in our studies? As you know, I'm interested in the neurological soft science. That could be one of the science, but maybe more generally, how do you explain that this part is not part of the brain and part of the functions are not so well studied, and what should we move clearly with introducing that in all the trials that we are and studies we are conducting?
Absolutely. You know, I did my thesis in neurophysiology with a focus on the cerebellum. And I think it's the most neglected brain area in psychiatric neuroscience. unfortunately. But what we see, at least, and this is really the evidence that it's in front of us, is that for most of the predictive tasks that use imaging, the cerebellum is key. And it's not a big surprise, because the cerebellum is basically not just coordinating movement, and this is where I think the neglect comes from, because people thought the cerebellum, okay, that's a part of the neural movement system. It's not. It's most of the connections of the cerebellum go into the prefrontal cortex. They are the bulk of the connections. And not only that, most of the neural systems, such as the default mode network, the salience network, different parts, different functional systems have a representation in the cerebellar hemisphere. So they are also accessible via the cerebellum for interventions. And as you may know, Ingrid Beck, for example, from Switzerland, from Geneva, they are studying that. They also study interventions on the cerebellum, along with other people. Definitely, it's worthwhile exploring this further and modeling specifically the role that the cerebellum has in the pathophysiology of schizophrenia. Of course, there are theories around that you know, all theories by Nancy Andreasen, but it might also be involved in depression and anxiety disorders. So I know that there are studies which stimulated people which underwent surgery, and where the cerebellum was stimulated. They developed all sorts of emotions like anxiety or depression through the stimulation in the specific area. So it has this very important role in psychiatry as well.
Okay, so and I'm very also very I think it's very good that you introduce that artificial all these algorithm and artificial intelligence can help also to have a more optimized pathway to care and pathway care care pathway, sorry, and because that probably is a good way of optimizing and then have a human input
as well.
Yeah, okay. So
primarily, so it's
yeah.
not a replacement, obviously.
Yeah, and also we need to have some data that can be used in usual clinics, in clinical settings. That's why, yeah, of course, brain imaging is a fantastic tool, but also we should have an idea of what we could have in the first line analysis before sending people to the MRI. As you know, as you know, in the psychiatry project, we introduced this neurodevelopmental scores.
Yes.
We have then to check with the brain imaging whether it's good or not. Or maybe Marion, you have some questions yourself.
Well, I think it's really great to see some practical results from all this data coming out to make some practical prediction that can be used in everyday clinic. So I think it's really lots of hope in this field coming from your work, Nikos. So it's really very important. We discussed this morning multimodal databases with all the colleagues here. We're going to gather data during the future cohort. So I think it's good for them to see that we can really do something with all this data and they're not working for nothing. So I think this is an important message.
An important aspect maybe that I might not have emphasized enough is that before we enter that stage of using these algorithms in clinical reality, we have to seriously consider how we make our field more measurement-based in general. So we're not talking about AI, but using, let's say, brief scales instead of gut feeling-based assessments. So today I was on the ward rounds with my residents here. And when we do the ward rounds, I always ask them to show me the BDI-2 scores of the patients, right? Of all the patients, or that they do the SCL90. It's an old questionnaire, symptom checklist questionnaire, a self-rating questionnaire. Why I'm asking that is because it's not objective in the strict sense, but it changes the discussion. So our mood is changing all the time, right? So I might be tired the next time I do the walk round, or in 2 weeks I'm angry with something, and then this changes my appraisal of the patient. If we have numbers, if we have measurements, we can introduce some level of objectivity into the process, and at the same time we create the basis, the databases for these algorithms to be implemented into clinical reality as well. So this is maybe a bit of a call now for changing how we work also, which I think is crucial.
Nikos, then there is another question, which is the cost, and also the discussion between research, which costs a lot of money, and how this very large, extensive multimodal assessment give some clues on maybe less measures that can be used in real life. So have you any idea how this movement is going to be applicable in the future?
So we can try hard, Marion, to reduce the examination density with our modeling efforts. So as I showed you, I mean, we try to do this as much as possible, but in the end, society needs to have a discussion whether psychiatric patients can have an MRI scan as a standard, like other patients in medicine. Yeah? And I don't see any reason why we should not provide MRI scans to our patients as a standard, or why they should not have a genetic testing if it is needed. So the algorithms, all these analyses in the end serve a purpose to test whether these examinations have a value beyond exclusion diagnosis, beyond excluding neurological disorders. I believe so, but it needs to be demonstrated so that the payers in the end can change their benefit-risk estimations, basically, right? And provide the much-needed examinations to each and every individual who needs them.
Yeah, at the same time, Marion, just tell me if there is someone.
Yes, one hand.
Okay, one hand. Okay.
Yeah.
So go ahead.
You want to go in front, Amy?
Oh, good here. Thank you. Thank you very much for the presentation. Listening to this speech, there is an idea that we need maybe some standardized pipelines for evaluating the models. Because, well, it's nice to see some solution goes to production, but at the end of the day, we would like to benchmark them, compare with another one, and to bring more objectivity, right? Yes. So the question is, did you try to build some sort of evaluation pipelines that you can, or you would like to spread in the community?
That's an excellent point that you made. We have developed a model library, which is also accessible for external researchers. So it's also open source, so it's free. You just need to register. The URL is proniapredictors.eu. So if you go there, you can register, and the models, not all of them, however, many of those models are made accessible there. So you can enter data, you can upload MRI scan, processed MRI scan. We provide the pipelines that are needed to basically prepare the data, because the algorithms expect the data to be in a certain form, obviously a certain format. You download the script, you pre-process your data, you upload the data, and what you get is back is a prediction of the algorithm. This is one way of making that available, and not the only one. What else is possible if you use a specific software? For example, we have developed software for clinician scientists to use machine learning. It's called NeuroMiner. You can download it freely. When you train your model with NeuroMiner, you can enter an external validation mode where you basically can ship your model to colleagues around the world and let them run on their data and report, hopefully, back to you the results. So this is a means basically to not bring to not centralize data, which is extremely difficult, as we all know, right? And because you enter basically legal battles that take ages to be resolved. I prefer the other way. I prefer to bring the models to the data. And NeuroMiner and also other pipelines or other packages allow that. And this is urgently needed, I think, if we want to be serious about this field.
And this Eurominer is like standardized tool, right? In the community, it's well accepted and well used.
I would say it's relatively accepted in the relatively narrow field of psychiatric precision psychiatry and imaging. So there are a lot of papers, must be around 120 papers at the moment that have used the tool, not only from the extended Pronia people, but also from other colleagues around the world. So you can safely use it. It's continuously developed, not just by me, but a broader team of colleagues from the Munich team and also in London. And yeah, it unlocks a lot of methods that would be very difficult to implement for a clinician scientist if you don't have coding expertise. Yeah. Also, ChatGPT won't be able to solve all that for you. Yeah. So it has a value, I think. It has a niche, this kind of approach.
Yeah. Okay, well, I think we need to stop this very inspiring discussion because we need to move on. Nikos, thank you very, very much.
It's a pleasure. Thank you so much for the
invitation. Thank you very much.
See you, Nikos. Thank you very much for inviting me to comment this.
Have a great session.
And thank you, Marie-Odile, for chairing the session. See you soon.
Bye-bye. Bye.